Let's talk about circumflex humeral arteries. So circumflex humeral arteries. Let's watch a video first. Okay.
How do you pronounce
Wait. Let's watch a very short video. I think this will do.
and
Sorry for
welcome
the
back
ads,
to the
guys.
CMS Open Office Plan. Here let us discuss about the anastomosis around the scapula. Then this morning, we will discuss about anastomosis around the body of the scapula and that's anastomosis around the abdominal process. So in general, the scapula. So let us discuss in detail how these anastomotic channels are formed from these particular arteries. So here, as you can see, here is the first part of the subclavian artery. The first part of the subclavian artery gives us totally four branches. One is ascending cervical, inferior thyroid, transverse and suprascapular artery. The transverse artery intermediately gives off two important branches, one is the superficial branch and the one is the deep branch. So from the thyrocervical trunk, the suprascapular artery and the deep branch of the transverse artery are the ones which take part in the anastomosis around the body of the scapula. In the same way, the circumflex scapular artery, what you are seeing in the label wall of the scapula, the circumflex scapular artery, which is the branch of subscapular artery, and this particular subscapular artery, which arises from the third part of the axillary artery, take part in the anastomosis around the body of the scapula. So what are the three principal arteries which are taking part in the anastomosis around the body of the scapula? One is the deep branch of the transverse cervical artery. Second one is the suprascapular artery. Third are the branches from the thyrocervical trunk. And next one is the circumflex scapular artery, which is the branch of subscapular artery, which is arising from the third part of the axillary artery. This is what is called anastomosis around the body of the scapula. And then we see anastomosis around anterior process of the scapula. Anterior anastomosis is the
Sorry, I don't think this was the video that we had thought of, but rather let's just talk. Now see, okay, so this is brachial artery, which is a continuation of axillary artery from the inferior part of the teres minor and brachial artery. So this is brachial artery, and this is anterior circumflex humeral artery. So axillary artery comes from anterior circumflex humeral arteries, and from the axillary artery itself, posterior circumflex humeral artery occurs, and which encircle the neck of the humerus, and then branches to the humeral head is present. So branches to the humeral head is also present from the anterior part of the anterior circumflex humeral artery. So this forms the anastomosis around the neck of the humerus. Okay, now if the patient suffers from fracture of proximal humerus at anatomical neck, so if there is proximal humerus fracture at the anatomical neck site, humeral neck fracture occurs and falls, especially in aged more than 65 and with osteoporosis. They often occur as associated injuries, but may also be associated with glenohumeral dislocation. The proximal humerus and glenohumeral joint receive the blood supply via the anterior process of artery. So proximal humerus as well as glenohumeral joint. So humerus, the head of the humerus as well as the glenoid cavity of the scapula receive blood supply via anterior process of humeral arteries with a branch of the artery that form an anastomosis and then the neck of the humerus in the quadrangular space. So this anastomosis occurs in the quadrangular space. This anastomosis gives rise to intraosseous arteries. So intraosseous, the arteries also go inside the bone that travel back to the humeral head. Humeral neck fractures can disrupt this retrograde. So they give rise to intraosseous artery that travel back to the humeral head. So from the anastomosis in the neck, the intraosseous artery go to the head, humeral head. So this, if there is fracture, then this retrograde blood flow to the humeral head is cut off, leading to avascular necrosis or osteonecrosis of the humeral head. Osteonecrosis presents insidiously with shoulder pain, decreased range of motion, and flattening of the humeral head on X-ray. So there is osteonecrosis, then there will be pain, movement is restricted, and there will be flattening of the humeral head on X-ray. Okay, now let's talk about the axillary nerve. So in the posterior surface of the axillary nerve it looks like this. Okay, wait. Teres minor muscle. So let's see the muscle one by one. So this is teres minor muscle. So this red color part is teres minor muscle. Okay, this is the deltoid muscle, and this is the bone, humerus bone, and these two are triceps head of the triceps muscle. So this 1, 2, and posteriorly these 3. There are 3 heads of triceps, therefore there are 3 triceps muscles. So the quadrangular space of teres major. So this is teres major. So teres minor. So teres minor is there. Teres major is here. Teres minor is in the upper part. Teres major in the lower part, and the 2 heads of the biceps form the medial and lateral part of the quadrangular space. This space is called quadrangular space, from which axillary nerve also passes. So axillary nerve passes through this quadrangular space, as well as axillary artery. The interosseous part of the axillary artery had also gone through this space. So it is a very important space. Quadrangular space is a very important space. Okay. Then, so biceps tendon rupture. So the biceps tendon rupture presents with weakness of shoulder flexion. So there is weakness of shoulder flexion and a noticeable bulge in the anterior arm. So there will be weakness of shoulder flexion and noticeable bulge in the anterior arm. So noticeable bulge is present in the anterior. So in the anterior arm, there will be bulge present, which is very noticeable. It most commonly occurs due to chronic overuse tendinopathy or acute forceful contraction of the biceps. So acute forceful contraction of the biceps can cause biceps tendon rupture. So biceps tendon can rupture because of forceful flexion or contraction of the biceps, but humeral neck fracture does not usually disrupt the tendon. So but humeral neck fracture, so if there is a fracture of the humeral neck, it does not disrupt the tendon. So the tendon is not disrupted. Okay. Now choices B and D. So supracondylar fracture may injure the brachial artery and median nerve where they pass anterior to the distal femur. So supracondylar fracture. So it is a very common fracture and Fuchs injury that may injure the brachial artery. So brachial artery can be injured. So supracondylar fracture. So just above the condyle, if there is fracture, then brachial artery can be damaged and median nerve can also damage. So median nerve and brachial artery both can be damaged in the where they pass anterior to the distal humor. So where they pass anterior to the distal humor, these structures are not at risk from proximal humerus fracture. So these structures are not at risk from proximal. So proximal humerus fracture does not cause any of this risk, but brachial nerve. So brachial artery is the most important artery, and the median nerve, the most important nerve, pass anterior to the distal humerus. So they pass anterior to the distal humerus. So the injury to the supracondylar fractures may disrupt them. Okay, supracondylar humeral fracture. So anterior displacement, so anterior lateral dislocation of the proximal fragment or anteromedial displacement. So the displacement can be anterolateral or anteromedial displacement. Okay. In the medial epicondyle, so here is the medial epicondyle. So here is the medial epicondyle. Just medial to the medial epicondyle is a nerve, which is median nerve. So this is median nerve, which is very closely approximated to medial epicondyle. So just lateral to the medial nerve is brachial artery. So these two arteries are most important arteries, so this is a lateral epicondyle, and the just medial to the lateral epicondyle is radial nerve. So radial nerve can be injured if there is anterolateral. So if there is anterolateral displacement, then laterally there is a radial nerve. So radial nerve can be injured, while medial displacement can injure median nerve. So that is a very well-known fact. So as well as the vessel. So brachial artery can be injured in median displacement, while in the lateral displacement there is some artery can also be disrupted. Which artery is this? So this artery can also be injured. Okay. So the radial nerve and deep brachial artery. So deep brachial. So this is a deep brachial artery. So this is a brachial artery. The deep brachial part is this. So from the brachial artery, deep brachial artery arises, which runs laterally, and therefore lateral. So deep brachial artery comes injured in lateral. In the lateral, fracture of the anterolateral displacement of the humerus. So the radial nerve and deep brachial artery run posterior to the mid shaft of the humerus and may be injured at the fracture at that point. If these structures are not typically injured in the humeral neck fracture, so in the neck fracture, the upper part of the humerus, there is no any injury to these vessels. Deep brachial artery and radial nerve. So proximal circumflex artery. So this is axillary artery, from which this is axillary artery. So this is axillary artery, from which posterior, anterior, and posterior circumflex arteries arise. Okay, this runs downwards and form brachial artery. So from the brachial artery. So from the brachial artery, there is a deep brachial artery and superficial brachial artery. So this is a superficial brachial artery. Okay, and the radial nerve. So radial nerve runs along the deep brachial artery, and in the mid humerus there can be an injury. Okay, all right, buddies. So now let's talk about lateral epicondylitis. Okay, so let's search about lateral epicondylitis. Okay, lateral epicondylitis. This was a very small video. So tennis elbow. Okay, I think this will do.
Hi, this is on definition of tennis elbow, which is also known as lateral epicondylitis. So lateral epicondylitis definition.
Okay, I think this makes sense. The patient has pain over the lateral epicondyle of the humerus, so it's lateral epicondyle. So it's not the inflammation of the lateral epicondyle, but rather there is repeated overuse of lateral epicondyle. Okay, and lateral epicondylitis is classically seen in tennis players due to repeated wrist extension, backhand strikes, transmitting sudden extreme forces through the lateral epicondyle. Okay, the lateral epicondyle is also the primary external carpal radialis brevis and extensor digitorum. So extensor digitorum and extensor carpal radialis brevis. They're the primary muscles involved in wrist extension. So overuse of this muscle can cause repeated microtrauma of the tendons at the origin of the lateral epicondyle, leading to angiofibrotic tendinosis. So angiofibrotic tendinosis occurs. So angiofibrotic tendinosis occurs. Okay, angiofibroblastic tendinosis occur. Okay, excessive fibroblastic neovascularization. So there is excessive fibroblast and neovascularization at the sites without a significant inflammatory infiltrate. This will cause swelling and pain over the lateral epicondyle and proximal extensor tendons. Or overuse the wrist flexor muscle can go to medial epicondyle, for example. Overuse the flexor muscle can cause, for example, golfer's elbow will cause medial epicondylitis, while the lateral will cause lateral epicondylitis, which occurs by similar proceeding tendons of the flexor muscles near that of the medial epicondyle. Abduction of the femur is primarily accompanied by palmar interosseous muscle, which originates from the metacarpal. So abduction, so PAD. So palmar interosseous helps in abduction, while PAD, DAP. So dorsal interosseous helps in DAP. So DAP means abduction. So flexion of the forearm is primarily by biceps brachii, brachialis. So flexion will occur because of flexion of the forearm occurs because of biceps brachii, brachialis, and brachioradialis muscle, none of which muscles are on lateral epicondyle. Shoulder abduction, which is primarily accompanied by supraspinatus. So shoulder abduction of the shoulder is helped by supraspinatus and deltoid muscle. So supraspinatus helps in 0 to 15 degree of legs abduction, while deltoid muscle gives it to 90 degrees. Overuse of supraspinatus leads to supraspinatus tendinopathy, root of tendinopathy. So overuse of supraspinatus muscle will lead to supraspinatus tendinopathy. Overuse of now abductor pollicis longus, thumb abduction, and extensor pollicis brevis. So an extensor pollicis, thumb extension. So thumb abduction and thumb extension, abduction. So abduction. So thumb abduction by abductor pollicis means abduction of the pollicis means thumb. So abductor pollicis longus. So abductor pollicis longus and extensor pollicis brevis. So extensor pollicis brevis, thumb extension. So abduction and flexion. Flexion means this, extension this. So abductor pollicis longus and extensor pollicis brevis can result in decurvent tendinopathy. So decurvent tendinopathy or synovitis can occur, which cause thumb and wrist pain. Okay. So extensor retinaculum means this is the extensor retinaculum. So abductor pollicis longus and extensor pollicis brevis. Abductor helps in abduction, while extensor pollicis brevis helps in extension of the thumb. So thickened tendon sheaths occurs. So extensor retinaculum is very thick, and it traps those two muscles, leading to decurvent tendinopathy. Okay, so let's talk about IgA vasculitis. IgA vasculitis. Okay, which is a sort of form of video. I think this would be short. Sorry for that, guys.
Just me. You can find me tonight on this topic and 05/HSD.
Okay, then let's talk about so the purpose of deposition of IgA in small vessels activates complement. So there is IgA deposition in the vessels, and the activation of complement occurs. Neutrophilic inflammation and vascular damage also seen. So there is now after the complement is activated, the neutrophilic inflammation occurs, and blood vessel is also damaged. It often follows an upper respiratory tract infection. So it follows an URTI, so upper respiratory tract infection. Now, clinical manifestations are palpable purpura, pedicity, or on the lower extremities. So there is purpura, so there's arthritis, abdominal pain, and renal disease, and the bleeding, interstitial, and renal disease, hematuria, plus minus proteinuria. Diagnosis is clinical in skin biopsy, leukocytoclastic vasculitis. So leukocytoclastic vasculitis is seen. IgA deposition in vessel wall is seen. The patient's abdominal pain, purpura, and hematuria constitute HSP, and IgA vasculitis of the small disease, small vessels. Sorry. The most common presenting symptom is non-blanchable. So non-blanchable purpura over the back, buttocks, and lower extremities as seen in the patient's colic abdominal pain due to a local vasculitis is also very common, and other findings include arthralgia with the hip, knee, or ankles. Renal deposition or involvement occurs in over one-third of children with HSP is due to mesangial deposition of IgA containing immune complexes similar to IgA nephropathy. So IgA nephropathy, most patients, especially young children, develop mild nephritis due to hematuria, red cell cast, or non-nephrotic proteinuria. So serum protein is typically normal or slightly elevated. However, more severe complex AKI can occur in a majority of patients. So this is renal disease, abdominal interception, arthralgias, and palpable purpura on ankles, buttocks, and thighs can also be seen. Okay, this is the purpura. Membranous nephropathy is nephropathy. It's characterized by thickening of the glomerular basement membrane. So membranous nephropathy means thickening of the basement membrane occurs. So this is glomerular basement membrane occurs. It is far more common in adults than children. So it's common in adults and children. Presents with edema and nephrotic proteinuria. So it presents with edema and nephrotic proteinuria. Moreover, purpura would not be expected. So purpura would not be expected. So purpura would not be expected. So Goodpasser syndrome, which typically affects adolescents and adults, is characterized by glomerular nephritis due to linear deposition of IgZ deposits. So IgZ deposits occur in the linear fashion. Okay, and Goodpasser syndrome, which typically affects adolescents and adults, is characterized by glomerular nephritis. So glomerular nephritis occur due to linear deposition of IgA antibodies on the patient membrane. So linear deposition of IgA antibodies on the patient membrane occurs. Associated findings include pulmonary hemorrhage, not purpura or abdominal pain. So pulmonary hemorrhage as well as hematuria, both of them are seen in Goodpasser syndrome. It occurs due to linear deposition of IgA antibodies in the basement membrane. So in the basement membrane, there is glomerular basement membrane. Then there is IgZ deposition, means IgZ means Z for Goodpasser syndrome, Z for IgZ deposits. Okay. Focal segmental glomerular sclerosis (FSGS) typically presents focal segmental FSGS presents with edema or proteinuria in adults and is characterized by localized regions of mesangial sclerosis and collapse on light microscopy. So on light microscope. So mesangial sclerosis occurs. So focal sclerosis means there is thickening of the basement membrane or the mesangium. So mesangial thickening occurs at some point. So localized thickening, localized thickening of the mesangium occurs and collapse on light microscope. This is the A's and purpura makes the light diagnosis unlikely. Fusion or flattening of podocytes occur in minimal change disease. So, okay, the most common form of nephrotic syndrome in children. So is a minimal change disease (MCD). Patients have proteinuria and edema, not hematuria and rash. So similarly, subepithelial immune complex depositions characteristics of PSGN. So subepithelial immune complex deposition. So there's domain spike pattern. So subepithelial immune complex deposition. So subepithelial immune complex deposition is characteristic of PSGN, which can present with hematuria weeks after a group A Staphylococcus pharyngitis skin infection. So after group A pharyngitis or skin infection in impetigo, although blanching, erythematous or sandpaper rash can also occur in GAS. Scarlet fever, palpable purpura is not seen. So in group A Staphylococcus can also lead to scarlet fever, and which can cause some blanching, erythematous, and sandpaper rash. All right, so dermatomyositis. So let's talk about dermatomyositis. Let's talk about dermatomyositis. So I think this is a long video, and I think this would do. Generally, okay, let's see. let's learn the topic and then test ourselves. So dermatomyositis is autoimmune disorder characterized by cutaneous manifestations. Dermato means cutaneous manifestation like gout and papules, red viruses, plateau papules over joints and proximal bone and bony permissions, especially in the hands, and heliotrope rash, erythematous viruses, edematous eruption in the upper lids, and pure virus skin, and myopathy means proximal muscle weakness, and polymyositis, elevated enzyme CK, and although levels are elevated. Autoantibodies include ANA is more sensitive, while anti-Zo1 antibodies are more specific, are frequently positive. Muscle biopsy comes with diagnosis and shows perifascicular inflammation. So, and around the fascicles of the muscle, so around the muscle fascicles, there is inflammation and atrophy affecting a contiguous portion of the fascicle and surrounding blood vessels. So, it affects a contiguous portion of the fascicle and surrounding blood vessels. Initial treatment includes systemic prednisolone. Dermatomyositis may occur alone or with paraneoplastic syndrome associated with malignancy, like adenocarcinoma of the lungs. Affected patients should be evaluated for underlying occult malignancy as well. This is heliotrope rash. So acetylcholinesterase inhibitors like physostigmine are used in the treatment of myasthenia gravis, with presence with fluctuating and fatigable weakness that primarily involves the ocular, bulbar, and respiratory muscles. The skin is not typically involved. So see, acetylcholinesterase inhibitors. So acetylcholinesterase inhibitors like physostigmine are used in the treatment of myasthenia gravis, with presence with fluctuating and fatigable weakness that primarily involves the ocular, bulbar, and respiratory muscles. The skin is not typically involved. Okay, acetylcholinesterase inhibitor means physostigmine is used for myasthenia gravis. So there is weakness in the ocular, bulbar, and respiratory muscles, and the skin is not involved. Copper deficiency involves presence with muscle weakness occurs, anemia occurs, and fragile hair. So fragile hair, so kinky hair occurs, anemia occurs, and there is muscle weakness as well. Skin hypopigmentation is also very common, but rash does not occur. Riluzole. I think it's an ALS treatment. It is used on treatment for ALS. Is a glutamate inhibitor. So it is a glutamate inhibitor that is indicated for amyotrophic lateral sclerosis, a progressive neurodegenerative disorder that affects both upper and lower motor nerves. Although proximal muscle weakness may be seen, lower motor neuron dysfunction, upper motor neuron signs like bulbar dysfunction, hyperreflexia are expected, and the disease is not associated with skin rash. So, see, it's a progressive amyotrophic lateral sclerosis. It means amyotrophic, so there is no muscular growth. Lateral sclerosis occurs. It is a neurodegenerative disorder that affects both upper and lower motor nerves. So it most commonly involves upper and lower motor nerves. So bulbar palsy occurs. So there is although proximal muscle weakness will be seen because of lower muscle dysfunction, proximal or lower motor nerve dysfunction can occur. So this proximal muscle weakness can be seen. Upper motor neuron signs like bulbar dysfunction, hyperreflexia. So bulbar dysfunction, hyperreflexia are also expected and is not associated. ALS is not associated with skin rash. That is a very well known fact. Riluzole is a drug that is used in the treatment of ALS. So it is ALS, which is a progressive neurodegenerative disorder affecting both upper and lower motor nerves. Hypothyroid myopathy, common presence with proximal muscle weakness. However, unlike polymyositis and dermatomyositis, patients usually also have prominent muscle pain and often have other hypothyroid features. Okay, let's do it up to here, and we'll be continuing the later parts later. Thank you, guys.